And it's many times a day that I miss MIT, particularly the sense of humor. This is the undergrads that have hacked the Green Building to play Tetris on it. So I figure if they're smart enough to learn to play Tetris on the Green Building, that a cure for cancer can't be too far behind.
We'll begin the program with a presentation by Dr. Knopf. He's a clinical oncologist and director of the San Francisco Cancer Center. In his practice, he treats the entire spectrum of hematologic and oncologic conditions with attending privileges at California Pacific Medical Center. He also directs the oncology clinic at St. Luke's Hospital in San Francisco. Obtained his undergraduate degree at MIT. Didn't take any time off. He went straight to getting his MD at UCSF and has been a highly productive clinician ever since. So we'll start the presentation with Dr. Knopf. Thanks.
It really is an honor to speak before such an illustrious audience. So we're going to go over an overview of challenges in cancer. This may take a little longer than 10 minutes. I tried rehearsing once or twice. And I'm a general oncologist, so I see whatever comes in. I still retain some curiosity about things that I learned during my 4 years at MIT. And it's many times a day that I miss MIT, particularly the sense of humor. This is the undergrads that have hacked the Green Building to play Tetris on it. So I figure if they're smart enough to learn to play Tetris on the Green Building, that a cure for cancer can't be too far behind. So at an MIT, when you're an undergrad, you have problem sets. So I've created a problem set for tonight. We only have two problems. Number one is we're not curing enough cancers. And number two is we need more funding for R&D. So we've got a room full of very smart people. We only have an hour, so we're going to have to get partial credit on this. So we'll go forth, and I'll try and define some of the elements of the problem, and then we'll go about a solution. So these are the main goals of cancer care. These are the things that you ask yourself whenever a patient comes in the office. The first goal, which we always want, is to be able to cure a patient of cancer. The second goal is to prolong their survival, and by that we mean that they live a lot longer with a good quality of life. And then the third goal is just to palliate. And since I've been practicing for the past 12 years, we've seen a dramatic shift from palliate to prolonged survival. We haven't seen quite as many improvements in cures, but that's where we want to go. But we've got a lot of new medicines that are keeping people a lot longer, and that's a big bonus for us. So some people would say that one of the ways to cure cancer would be to make it a disease like diabetes that you control for a number of years, and then in effect you have cured somebody. This is a patient of mine who's cured. His name is Ken. He had a diffuse large cell lymphoma, and he got a chemotherapy regimen called R-CHOP. R stands for Rituxan. It's a monoclonal antibody that was developed by scientists here at Genentech, the first monoclonal antibody to be commercialized. And you see a little bit of its target there. When you add it to chemotherapy, you get synergistic cell kill. So this is one of those unusual medicines, there are probably only 3 or 4 in the past 12 years, that can increase your chance of curing somebody of cancer. And Genentech really has another great drug called Herceptin and a third drug called Avastin that we use a lot in the clinic. So we're going to talk about some facts here. This is from a Talking Heads song. And unfortunately, facts don't do what we want them to in cancer. So we have a tough target there. And we're also going to talk about some facts of the U.S. healthcare system, which complicates our ability to both treat cancer and develop new drugs. So this is a little bit of what Wendy will go over. But the FDA approves drugs and devices that are safe and effective. That's their limit there. But in the UK, we have organizations called NICE in Western Europe that look at the cost effectiveness of drugs and devices. So for example, there's a therapy for prostate cancer called Provenge, which is a vaccine which extends survival about 4 months. And you can calculate a cost effectiveness ratio for that of $300,000, which is very expensive by any metric that you use in sort of league tables and things like that. So health economics is a very interesting thing. It's a zero-sum game. Which makes it very interesting. People spend a lot of effort and agony over many zero-sum games, such as the stock market is another zero-sum game, or the World Series, or the Super Bowl. These are all zero-sum games. What's interesting about healthcare is that there's so many players in this game. It makes it much more complicated. So in the Super Bowl, we just have the 49ers versus the Ravens. But in healthcare, we have at least 20 or 30 people all competing within this game. And each of their perspectives may differ from the other people's perspectives. And this is from another MIT alum. There was actually a sim game where you could play healthcare economics for fun with all these players here. So Some things are really, really innovative, and some things are not quite so innovative. But this is innovative in a sort of way, and this is just a little freshman organic chemistry. So this was a drug called Prilosec, which was used for acid reflux disease. And when the drug went off patent, the company decided to re-engineer the drug so that they had another branded drug. And what they basically did, this person says it's astonishing pharmaceutical ingenuity, is they cut the molecule in half, submitted that to the FDA, and got that approved. And then they got all the doctors to prescribe it. So they made $1 billion a year profit from this. So in the healthcare game, we'd say that the drug company won big here. And there's a question about who lost. Did the patients lose? Did Medicare lose? Did the payers lose? We could say that this was $1 billion that all went away from healthcare. But in actual fact, this is a company that spent a lot of money developing drugs for cancer over the past 10 years. Since this drug was introduced. And so far, I think they've had one drug that made it past the FDA for a small indication in thyroid cancer. So investing in healthcare is a high risk, high game. This is engineers' approach to the healthcare system. There's a lot of entropy and friction here. And I think that we could re-engineer the system here to free up a lot of money for cancer research. So if you look at this, there's about $700 billion a year of waste in the healthcare system. Unwarranted use, over-testing, administrative claims, duplication. These are all sort of errors that we make in the healthcare system. And if we could undo these errors somehow, we could free up $700 billion a year for cancer research just from the public funding. This is sort of a depressing slide if you think about it. So the red line down there, the E&M, that's how many patients the doctors see. That's evaluation and management. But if you look, that we see a tremendous amount of testing and imaging ordered for the same amount of patients. And we actually don't see a big improvement for outcomes for all this money we spend. So again, I would consider this sort of friction to the healthcare system. And just today I saw this article come up from Forbes that if you rate your doctor, it could be bad for your health, because if you give them a bad rating, they're going to try and get a higher rating by ordering more tests and procedures on you. So this is something that I think the doctors are really starting to wonder about and finally starting to do something about. In fact, there's a campaign by the internists called Choosing Wisely, which is sort of informing doctors how to think better about what they do. So this one says, don't do imaging for an uncomplicated headache. So in case you didn't learn it during medical school, you know, not everybody needs a CT scan if they come into your office for a headache. This is a complicated concept even for, I think, oncologists to get. But when we have screening, there's an epidemiologic concept called lead time bias. So you may have the onset of disease very early, and you may be able to pick it up very early, but it may not affect your overall survival if it's a very slow-growing or indolent process. So in this example, we have somebody who can be picked up with a cancer from 1989 versus 1992 when they have symptoms, but they live the same amount of time. So it's a lead time bias of about 3 years, which is sort of in the patient's worst interest to pick up something early if you're not going to make a difference, and economically will double your costs. So whenever we talk about screening programs or surveillance programs, we have to put in whether there's a lead time bias there. And this is a problem with early detection of recurrent cancer, because a lot of times picking recurrence up early won't make the patient live any longer. They just might start getting treated a little bit early. So this is something we actually want to avoid. I think this is like the only molecular biology slide I put in, but cancer, particularly epithelial cancers, is a multi-step genetic process. So what you're looking at on the left is a lumen of breast tissue, and then what you're looking on the right is a cancer. And as it goes from normal tissue to proliferative tissue to cancer, it acquires different oncogenic changes along the way. So these accumulation of genetic changes move it from benign tissue through ductal carcinoma in situ through invasive cancer. And so what we want to do here is, rather than maybe diagnose it early, we want to be able to pick it up early and then alter the biologic pathway so that we take those genetic changes away. And this is where molecular biology and I think engineering can help a lot. So we want to maybe identify these oncogenes and change them back so that cancer cells don't appear, and treat this in vivo. So there's actually an FDA-approved medicine called tamoxifen that you can give to women who have some of these proliferative lesions that will decrease their chance of getting invasive cancer. So that was the first FDA drug approved for chemoprevention. But we expect that there's going to be a lot more sort of chemoprevention coming down the pike as we understand more and more about the molecular biology of cancer. This is a really tough concept, but you'll see this in the newspapers, and this would be a whole hour talk in itself, but we are overdiagnosing a lot of cancers. So this is a big problem in breast cancer and prostate cancer in particular. So in breast cancer, the latest estimates are that we diagnose about 1.3 million American women with breast cancer who didn't need to be treated. And with things are as they are in America, once you're diagnosed, you're down the pathway of surgery, and maybe radiation, maybe chemotherapy, maybe hormonal therapy. So what we don't know is how to judge these cancers that may be indolent and slow growing and not do all this stuff for the patient that may not really help her in the long run. And as our imaging gets better, as we use MRI to screen people for breast cancer, we're going to pick up more of these background cancers, and we may be doing more harm than good. Some estimates say that we're overdiagnosing 3 to 1 sort of indolent cancers to real cancers. But the idea of having a cancer is such a fearful concept that this is a very hard concept to really get across to people. It's a little bit easier in prostate cancer because there's been so much in the literature by Dr. Brawley and other people that the prostate cancer is not necessarily cancer that's going to grow and metastasize and cause damage to the host. If you look at the statistics, if you're an 80-year-old man, you have about a 50% of having prostate cancer if you look at it. So obviously more men die with prostate cancer than of prostate cancer. And as we got screening better with PSA, we're getting a lot more early stage disease that's diagnosed. So even at our institution, for patients that have very early stage disease, such as what we call a Gleason score less than 6 and a low PSA, we're observing some of these men. So this is a big area where I think we could improve what we do by understanding what molecular biologic changes are with these cancers that might herald whether they're going to progress to a point where we need to do something about them versus just watch them. And to me, if you had a sensor you could implant in the prostate that would sort of get hooked up to a gene chip and tell you this cancer is sort of just indolent, leave it alone, versus there's some changes here you need to operate, that we could help with this problem of overdiagnosis, which is a very complicated problem in oncology. Just because we're from MIT doesn't mean that more technology is always better. And Ezekiel Manuel, who's also an oncologist, wrote about this in the New York Times in January 2012. So proton therapy for prostate cancer is very cool. It's got very interesting physics. You get a better penumbra. You get better treatment definition. But for the patient, you don't cure them any more often. You don't actually improve anything that we can tell. But it's become very fashionable to do this, and it has a price premium of $50,000 with no increase in survival. So we would call that economic entropy, if we're going to use an economic term. And you play the healthcare game with this, there are going to be winners and losers. So the winners are the manufacturers of the proton therapy machine and the people who own the proton therapy machine, which are very distinguished cancer centers, by the way. However, you know, a classmate of mine from med school called me and said, should I invest $30,000 in a proton machine? And I said, oh, I don't know. But you do lose when you do this. So the health insurance companies and Medicare lose because they're paying $50,000 and getting nothing in return. Cancer research loses unless all the profit from this that MD Anderson gets goes back into cancer research. The patient may or may not lose. They probably don't lose a big way. They have the same survival. Businesses, which have to pay healthcare costs, they lose by doing something like this. And just because this is radiation, biotech and pharma are losing out because there's less research money for them. If we're doing our problem set, it would be a double mistake to overtreat a prostate cancer with proton therapy, so you've made 2 bad mistakes. No partial credit for that. This is a young patient of mine who's probably cured of breast cancer named Marissa. She's 4 years out. I think in this picture she's 5 months pregnant as well. And when she comes in the office, we sort of do a history and physical and see how she's doing and chat. But if she's not having any symptoms, the literature in oncology says don't do any surveillance testing. Don't do any tumor markers, don't do any scans. And so we have a reminder for oncologists. We have a list of 5 things we're not supposed to do that are economically unsound, don't make sense. And this is number 4. And so number 4 was taught to me when I was a fellow at the NCI in 1996, but now it's just sort of getting to the general oncology community. You can do a little economic analysis here. You avoid an unnecessary blood test, an unnecessary PET scan. It frees up $8,200 for cancer research. You do that 10 times, you have enough for a postdoc in a lab. So when these patients come in, you know, it behooves us to be careful not to order tests that aren't going to help them. And this is also a lead time bias problem. This is a young woman who's cured of Hodgkin's disease. She got a regimen called ABVD, which was developed in the 1970s at the NCI and the Milan Cancer Institute. So even though we haven't had any improvement in the chemotherapy for this disease since the 1970s, we still have a very high cure rate, 80 to 90% early stage disease. And here I use a PET scan to sort of stratify patients to see who can be spared radiation therapy. So we used to be very dogmatic that patients would get some chemotherapy and then they'd get radiation therapy to the residual area, and there are problems with that. But you can do an economic analysis of this. So an interim PET scan costs you about $8,000. You avoid radiation that costs you $20,000, and you save $12,000 per patient. In addition, you avoid giving radiation to the chest wall, which is associated with a very high rate of coronary artery disease, and secondary cancers. So this is a win-win-win for almost all patients, and this is where we want to take oncology clinically to be more cost-effective so that we're helping patients as best as we can. This is a very naive view of nanotechnology, but we'll let Dr. Seema tell us how this works. But when we give patients chemotherapy or radiation therapy, we're trying to kill cancer cells, actively dividing cells. And each time we administer one of these treatments, we kill a certain percentage of cells, but the remaining cells can repopulate and they grow exponentially, and pretty soon you can have a recurrence. So the reason we can cure Hodgkin's disease is that the chemotherapy is so good that we kill enough cells that the remaining cells can get captured by the immune system and get rid of. But in other cancers, we can't cure them because chemotherapy doesn't work well enough. So I was thinking that we could use maybe targeted approaches, including nano-based technology, to specifically target the residual remaining cancer and increase the dose intensification while sparing normal tissue, maybe increase our chance of cure that way. So when we give chemotherapy, the reason there are side effects is because collateral tissue gets involved, gets exposed to the chemotherapy, and any sort of dividing cell can have toxicity from that. But if we have specific therapies, we'll treat the cancer and we won't cause toxicity. So this approach may increase the number of cancers that we can cure. In 20 years of medical school, I think this is the only time I had to use a logarithm. And doctors can only do logarithms in base 10, so these are what we'd call an unnatural logarithm. On the left is a diagram of how we kill cancer cells with radiation. And the lower values there are obviously more cancer kill. And one of the things about radiation is the way it works is the radiation generates free radicals by oxygen molecules, and those attack cancer cells and cause programmed cell death or apoptosis. So you're going to do a much better job of killing cancer cells if you have a highly oxygenated area. If it's deoxygenated, you need a much higher dose of radiation, and you may not be able to kill that cancer. So oxygenation is sort of the key. When you radiate a tumor, you sort of do it in multiple fractions so that the rim there can get oxygen to it so you can keep killing it. So this is one of the reasons radiation is given in multiple fractions. The one on the right is chemotherapy log cell kill. And so in the top example, we've got a chemotherapy that kills in magnitudes of 10 each time we give it, and we can get the cancer below the limit of detection, even say on a PET scan, but the patient has enough cancer cells that they're going to relapse eventually and potentially die of the cancer. If we have a better log cell kill of 2, giving the same number of chemotherapy treatments, we can get them down to a very low level where they may be cured. So one strategy that may work is to combine some conventional chemotherapy to get us down to a very low log order of cancer cells, and then use something that's really specific to target the remaining cancer cells. And this is a way that I think we could increase our chance of cure from what we have now, which is not as high as we'd like. This is another patient of mine named Steve and his wife Sandy, and he has a cancer called multiple myeloma. So when I started 12 years ago, people with myeloma lived about 3 years, and since that time we've had the introduction of 5 new drugs, and now we've got the median survival up to 7 years. Some patients go 10 years. So we're not curing these people. We're on that prolonged survival, and we think if we have enough drugs, we can keep them alive longer. But in this disease, some people will do a stem cell transplant to try and kill that remaining last group of cancer cells. And it doesn't work to increase the chance of cure. But this seems like a situation where it would be ripe to try something that would kill that remaining 1 or 2% of cells. And economically, if you have something that cures a cancer, it usually is going to turn out to be cost effective because of the way the denominator works. So I thought I'd close with just ovarian cancer, which is a tough problem to treat oncologically. Obviously, if we can screen a cancer and prevent it from happening, no matter what the organ, that counts as a cure. So any improvement in screening that we make would be great. And then if we can increase the cure rate with treatment, that would be great. So ovarian cancer, we have a certain subset of women who have a gene line mutation, a germline mutation in BRCA1 or BRCA2. These are DNA mismatch repair enzymes of a sort, cell checkpoint enzymes. And if they acquire a second hit, they're at high risk for getting breast cancer, ovarian cancer. And right now, we don't have really good screening for them, so a lot of them are electing for prophylactic mastectomy or prophylactic oophorectomy, having their ovaries removed after they've had children. And even the best screening tests we have right now in this very enriched population where the pretest probability of disease is much higher doesn't work very well. So what we want to do is have a better approach to increase our screening yield, to be more specific and have a better positive predicting value, where we could maybe say to a woman, yes, you have BRCA2, but your ovaries are fine, you're not going to develop cancer, just go on. Or we could monitor them over time and say, you know, we're seeing some dysplastic changes here, and this oncogene's on, and this oncogene's on, maybe it's time to have your ovaries taken out. and maybe we could avoid some women having to have surgery, stratify their risk, and give them some better information than we're able to give now. Ovarian cancer is an interesting cancer to get this approach as well because of the geography of it. So most of the women that we see who are diagnosed with ovarian cancer have disease throughout their abdominal cavity at the time of diagnosis, particularly in the omentum, in the lining here behind the stomach, and ascites, which is fluid there. So when we have these patients go to surgery, they really debulk all the tumor they can, and they give you a report on how much disease is left in the omentum in terms of millimeters. So what you like to have is minimal residual disease, the less the better. And then we follow this surgery with chemotherapy. For many years we gave this intravenously, and it would distribute to the cancer cells in the abdominal cavity. More recently, a lot of oncologists have embraced giving it intraperitoneally, where we put the chemotherapy inside the peritoneum, and we have the patient rotate so that the chemotherapy can actually get to the tumor pockets on the omentum, and there it becomes sort of a surface area physics problem that I guess would be good for 801. But what we want to do is be able to intensify the amount of chemotherapy we're giving to these remaining tumor nodules while sparing the normal organs. So if we can dose intensify chemotherapy here by giving it specifically to the cancer and targeting it in such a way, we could probably increase our cure rate for these patients from the 40 to 50% we see now, which is not what we'd really like, to something more like 80 or 90%. So research here might be very fruitful. And it might be easier to do something here than it is in a cancer that's sort of diffusely metastatic, where it's harder to get the therapy to the area, so if it's hiding out in the bone or the liver or the lung. So I think I've got 10 minutes down. This is our problem set. We've got some sort of way of approaching curing cancers that we can talk a little bit about more. And we talked a little bit about funding. We talked about an easy $700 billion to try and get from the system to fund R&D. So I think we've got enough partial credit to move forward. Thanks.
Maybe we have time to take a couple of questions. If you'd like to ask Dr. Knopf any questions about oncology. I guess we're trying to get this for the internet. There's a lot of people out there in the world who'd like to hear about this. So thanks for going to the speaker.
Yeah, you mentioned the approach of using, let's say, chemo to hit 98% and then using specific directed methods. And you mentioned this kind of approach in several of these areas. Is this still being done at experimental stage as to how much you do with chemo, how much you do with specifics, or is there already set up a method to determine how much of each and when?
Well, a lot of the ways we've done chemotherapy till now has been very empiric. Before we had breakthroughs in molecular biology where we could tell how we were killing cancer cells, we would just sort of try cancer cells and see how much we were killing. First in cell culture, and then maybe in mice, and then try it in humans, and then through clinical trials. So the idea of dose intensification really came only through the use of stem cell transplants, where we give very high doses of chemotherapy to try and kill every last cancer cell, and then we reinfuse stem cells so that the bone marrow can repopulate and the person has an immune system. And the example I gave of myeloma, we've done a lot of stem cell transplants in these patients, but we're not impacting their overall survival. So we're not able to kill that remaining 1%. So it would seem like what we want to do is focus in part, if we have good chemotherapy for a cancer, on getting a really great chemotherapy that can mop up that residual 1%. And so a clinical trial might have to be designed in several stages in order to reach that goal.
Hey, thank you for the talk.
Yeah.
One of the questions that I had is, what do you think about if all cancers were characterized at a molecular level, and then the benefit to research, if you could kind of crowdsource all that molecular data on cancers being classified at a molecular level, of that benefit to research and potentially finding a cure?
Well, there's a couple answers to that question. Definitely we're on the road of looking at molecular targets within cancer cells and trying to exploit that molecularly. I didn't put up any complicated molecular biology slides, but there's a lot of redundancy and multiple pathways in the system, so it might require 10 or 20 drugs to actually eradicate a cancer. And there's a lot of challenges. For example, if you look at a cancer and you take a sample here and a sample here, they may have different molecular characterizations. So, I think the Koch Institute is as likely as anyone else to sort of bridge molecular biology and engineering to solve this problem. How to get that data shared among colleagues and stuff is another complicated thing, because everybody wants to have their own sort of research agenda and their own sort of discoveries. There are a lot of programs for the NCI where genetic basis of cancer is shared online, and molecular biologists are starting to work together. And so I think this is maybe in a way in its toddlerhood. I think we'll see a lot more molecular biology and therapeutic targets identified over the next 10 years, just as we've improved the science.
Hi, my question is sort of related. At what point, you mentioned the whole issue of breast cancer screening and the cost-benefit analysis, and there's been a lot of discussion about that recently. At what point will there be enough data, do you think, in terms of correlating molecular signatures to specific breast cancer tissue to be able to be confident that it's definitely going to be an indolent cancer or there is a treatment that can positively affect the outcome?
Well, we've started to collect this molecular data on breast cancer, and we recharacterized it into several subtypes. We call them luminal A, luminal B, triple negative, and HER2 positive. And the luminal A is sort of the most benign one. And I think we're at a point where we can say that, like, for example, if a woman has luminal A breast cancer and has lumpectomy, her chance of a local relapse is much lower than somebody with a triple negative cancer. And in some of those cases, we can emit radiation. The gene chips are out there, and you get these green and red patterns. We're not at a place yet where we could sort of look at a cancer that's in a woman's breast and say, this one you can watch for a while. I think if people look in that direction, they might come up with ideas within the next 5 to 10 years. It's a very emotionally charged thing, the idea of having a cancer and not treating it. But the problem of overdiagnosis is actually, it's so much in the public's mind now that I'll have women come in who've had a breast cancer and say, really, I wonder if I could have let this one just sit for a while and it wouldn't have done anything. So I think things will change there to really starting to ask those tough questions.
Yeah, I used to work for Affymetrix for many years and was involved with genomics consortiums in cancer. And so I think there's an intersection at which point the cost of technology and the data are sufficient to make it so that no one has to go unscreened. That's
Right.
just really the point. And where's that turning point? So.
Right. Well, with screening, we talk about sensitivity and specificity, so we don't want to pick up a lot of things that are going to scare people, and this will continue to evolve in a good way, I think, for the patients.
Thank you for your presentation. I'm struggling with simplifying my question, which is there was an allusion earlier to the work being done at the Cancer Genomics Atlas at NCI looking at the biomolecular characterization of a variety of tumors. What do you see as the timeline and challenges to transitioning into the clinic in terms of physician education and building the infrastructure to support the kind of screening that can be done that will allow a much more targeted treatment of tumors on the basis of their molecular biology rather than their organ location?
I think the clinicians are already savvy to looking at molecular characteristics. For example, a common one is if you're CD20, you can use Rituxan, and if you're KRAS wild type, you can use this drug. So I think the clinicians are there. Right now, we have a lot more tests than we know how to interpret. So I think it'll just sort of sort itself out over time.
Hi, thank you very much for a very accessible presentation, at least for me as a layperson. I'm a physicist, not a clinician, but I have an interest in cancer. And one of the things, just viewing from the outside, is that there's a zoo of different genetic and molecular forms that cancer takes. And so the forms of cancer treatment that I've been most interested in are those that work across a broad spectrum. I was hoping that you could comment on a few approaches that chemotherapy has, in chemotherapy, that have either reduced the toxicity to normal cells, to the rest of the system, or may allow for dose intensification. One is basically causing a fasting. The patient doesn't eat for a fairly long period of time, and anecdotally this reduces hair loss and problems with the digestive tract. What may cause is just a reduction in the cell division. if that works, you might be able to dose intensify. And there are a few things going into, I think, phase 1 and phase 2 trials now. And then there are approaches that are broad spectrum chemotherapies that target solid cancers, but they're prodrugs. They don't activate until they reach the anoxic core or hypoxic core of solid cancers. Unfortunately, those seem to have been, they're only going into phase trials with traditional chemotherapies. So one of the biggest advantages of being able to not hit the white blood cells, it seems to be falling by the wayside. But
You want to state a question, because we're kind of running short on time.
Oh, sure.
Well, I think there's a lot of promising approaches, and the road to actually getting them into the clinic can be difficult and hard and long, and longer than patients would like, for sure.
Thank you.
Thank you for your input. Thanks.
Thank you so much for this. The extended clinical trials process, of course, helps keep harmful drugs off the market, but it also holds back or creates hurdles for drugs that could potentially be helpful and save lives. It would also seem to me it tends to squelch the kind of proliferation of innovation bottoms up that you see in IT, for example. What are your thoughts on this overall? Is the net positive or negative, or how do you think about it?
Well, I think medicine is much harder and slower to innovate than IT because of the legal and human risks involved. But I was talking to Dr. Seema both on the conference call and before the talk here about the fact that you could use neoadjuvant therapy trials. You could take an organ that's intact and give a chemotherapy drug and see if you get a complete pathological response, and that might be a signal to a good cancer therapy rather than an extended clinical trial with long overall survival endpoints. So it's a process that requires really the approval of the FDA to change the endpoints for us to get these drugs approved.
Thank you.
Doctor, just a very quick question on your slide about prostate cancer. You mentioned that you need new technologies to assist in determining which ones will kill, which ones may not. You mentioned Gleason. I thought that was the sort of the purpose of a Gleason score. The higher it is, the more aggressive and so forth. Could you clarify that for me, please?
Yeah, I mean, the prostate cancers we're watching have a very low Gleason score and a low PSA. What I think I meant there is we need better things besides just Gleason score and PSA. We need some molecular tools to give us more information about which prostate cancers are sort of indolent and which ones are serious. So I think that's an area that's ripe for involvement of more molecular biology and maybe more devices to help guide us than just the PSA and the Gleason score we have. So those characteristics we have now are good, but they're not great. So that's all I really meant to say with that.
Great. Thanks very much. I'd like to say I think the audience had some really great questions. And I'd like to thank Dr. Kevin Knopf again for his contribution this evening.